Hi, everyone. Thanks for staying this evening. So great to have all of you here. My name is Dr. Leslie Randall. I'm from the United States. I live in the Washington, D.C. area and work for the Inova healthcare system, and I'm also the cervical cancer clinical trials advisor for the GOG partners, so have a lot invested in this space, and we're all happy or all very excited today to talk about global perspectives at this IGCS meeting in advanced and recurrent cervical cancer resources, opportunities, and access to care. We'll also hit on some of the work that we're doing in the prevention space just to illustrate how we can partner globally and think of innovative, creative solutions to get patients access to these newer life-saving and life-prolonging therapies that are coming online. So the IGCS would like to thank GenMab for their generous support of this symposium, and I'd like to introduce this esteemed panel that I have next to me. Professor Hasegawa, please introduce yourself.
Good evening, everyone. I'm Kosei Hasegawa from Saitama Medical University in Japan. I'm a GYN oncologist, and we do surgery and chemo both. And from this year, I'll be the new board member of the IGCS regional district. Happy to be here.
Excellent. And Professor Solani.
Hi, good evening, everyone. My name is Rithi Solani. I'm a GYN oncologist at UCLA in Los Angeles, California, and also very interested in cervical cancer and excited about our discussion today.
Thank you so much. The following are disclosures. And the learning objectives for this symposium are shown here. We'd like to review the current landscape for the treatment of cervical cancer, including pivotal clinical trial data and current insights. We'd like to understand the role of ADCs in cervical cancer and how to educate our patients on this novel treatment option. And then we'd like to also review and understand the prevalence of disease, prevention, available resources, and how those vary globally. So shown here is the agenda for today. So we'll start with Professor Hasegawa, who will talk to us about the current landscape. And we will try our best to stay on schedule. We apologize for starting late. And I think to advance the slides, we actually do have to go to the podium. Yeah, because we don't have a clicker. Yeah. Great. We were trying to be kind of lazy because it was the end of the day and sit down, but we'll go to the podium for you all so that we can advance the slides.
Okay. Good evening again. My name is Kosei Hasegawa from Saitama Medical University in Japan. Thank you for having me today. Always, I think so. I'm going to talk about the current landscape of recurrent cervical cancer, but I'm going to talk mainly about immunotherapy, and then Professor Sarani will talk about ADC today. So always, if we're talking about cervical cancer, maybe we have to start with here. WHO recommendation to eliminate cervical cancer by 2030. 90% of girls under 15 years old are vaccinated against HPV. 70% of eligible women are screened. 90% of women diagnosed with cervical cancer receive treatment. But the reality is, next slide shows the gynec cancer incidence and mortality in Japan and the United States. Japan's population is about 1/3 of the United States. However, the number of cases and death in Japan is only a little lower. So that means cervical cancer is more common in Japan than Western Europe. So one reason may be the lower rate of HPV vaccination and cervical cancer screening. In Western countries, the number of cervical cancer cases and death is usually decreasing. But in Japan, both are increasing. So cervical cancer is a very important issue for us too. 10 to 15% of cervical cancer patients have distant metastasis. their 5-year survival rate is around 20%. This means they have a very poor prognosis. This slide shows the treatment approach for cervical cancer. Before immunotherapy became the standard of care, patients with metastatic disease received platinum-based chemo with or without bevacizumab as first-line treatment. And after the disease progression, single-agent chemo was usually used as second-line treatment. Now I will focus on second and third-line recurrent disease. This slide shows the efficacy data of non-platinum second-line regimens. Most studies are small phase 2 trials. Some response can be seen, but PFS OS are poor. There is no clear survival benefit, maybe not very different with basic supportive care. As you all know, immunotherapy has now become available. PD-1, PD-L1 inhibition can block the inhibitory signals from tumor cells. This allows T cells to become active again and attack the cancer. This treatment has a completely different mechanism of action from previous treatment, such as traditional chemo. PD-1, PD-L1 pathway inhibitor is effective in highly immunogenic tumor, such as MSI-high. As shown in the Keynote 158 trial for MSI-high tumors, about 70% of the patients maintained their response for 3 years. So the effect is long-lasting and the duration of response quite long. Cervical cancer has a relative high mutational burden compared with other tumors. In addition, because it is HPV-related, viral antigen such as E6 and E7 are presented on the cell surface together with AHL class 1 molecules. This makes them an ideal target for immunotherapy because this is kind of foreign antigen. So cervical cancer may respond well to because of its high mutation burden and the presence of viral antigen that the immune system can recognize very well. Here we show the early development of PD-1, L1 inhibition. As you can see, the response rate is up to 20%. So why the response is not too bad, but it was not very fantastic at this stage. Let's focus on the cervical cancer cohort of the largest phase 2 trial, study 158 for the cervical cancer cohort. Even in PD-L1 positive patients, the response rate was only about 17%. However, looking at the duration of response, over 70% of responding cases maintained their response for more than 2 years. This was a result not seen with previous second-line treatments. Based on these findings, the FDA granted accelerated approval of pembrolizumab for PD-L1 positive recurrent cervical cancer, but not for us like Japan. To obtain more robust data, we need a level 1 evidence. A phase 3 trial was conducted in second-line cervical cancer. This trial, Emperor Cervical 1, compares another anti-PD-1 antibody, cemiplimab, with non-platinum chemotherapy. The primary endpoint was overall survival. In the next slide, you will see progression-free survival and overall survival curves for SCC and adenocarcinoma population. As shown, regardless of histology, cemiplimab improved both PFS and OS compared to chemotherapy. Cemiplimab was consistently more effective than chemotherapy across predefined subgroups, including histology, geographic region, prior BEP, and the number of prior lines of chemo. PD-L1 expression is often used as a baseline biomarker for immunotherapy in many cancers. In this study, PD-L1 data are available for only some patients. However, cemiplimab improved overall survival compared to chemotherapy regardless of PD-L1 levels. But we need to keep in mind this PD-L1 is not a combined positive score, but just staining the tumor cell. Notably, quality of life was formally analyzed in this trial. Red line represents the chemotherapy, and the blue line represents cemiplimab. As you can see, QOL decreased with chemotherapy over chemo cycles, possibly due to cumulative chemotoxicity. In contrast, QOL appeared to be maintained with cemiplimab. Next slide discuss combination with PERP inhibitors and ICI. PERP inhibitors are expected to have an immunomodulatory effect. Recent preclinical data show that PERP inhibitor can activate the CGA-STING pathway and release Th1 cytokine, which may enhance the immunotherapy. As you can see, several phase 2 studies are ongoing testing ICI plus PERP inhibitor in second-line setting of cervical cancer. Now, I would like to briefly introduce the results of our Gothic 025 trial. As you can see, the combination of pembrolizumab plus olaparib, the response rate was 4%, PFS was 3.4 months, and OS was 11.9 months. These results are similar to ICI monotherapy, so adding a PERP inhibitor appears to provide only a modest clinical benefit in this setting. Next, I would like to discuss first-line treatment. Let's look at the angiogenesis in cervical cancer. Persistent HPV infection promotes VEGF expression. VEGF positivity is high in cervical cancer. High VEGF expression is linked to poor prognosis. Angiogenesis inhibitor, such as bevacizumab, may be effective in cervical cancer. And as you all know, in the GOG 240 trial, this is a phase 3 trial, first-line treatment for cervical cancer was evaluated. Chemotherapy alone was compared with chemo plus bevacizumab. As you can see, adding bevacizumab improved overall survival. The slide shows evolution of treatment for recurrent and metastatic cervical cancer. With the addition of bevacizumab, overall survival was extended by more than 4 months compared to chemotherapy. Because immunotherapy has shown efficacy in the second-line setting, it is now being tested earlier setting in first-line treatment. In first-line therapy, immune checkpoint inhibitor combined with chemo. Chemotherapy may help release tumor antigen and activate the local immunity, which can enhance the effect of ICI treatment. Is this true? Do you have data to support this combination in human? We don't have the cervical cancer, but this is from ovarian cancer data. When we compare tumors before neoadjuvant chemotherapy and at the time of interval blocking surgery, we see an increasing in the T-cell inflamed phenotype in the local tumor. Yes, chemo may enhance local tumor immunity. In the Keynote 826 trial, first-line cervical cancer patients were randomized to either pembrolizumab plus chemo with or without bevacizumab, or placebo plus chemo with or without bevacizumab. The dual primary endpoint were overall survival and progression-free survival. The PFS benefit of adding pembrolizumab was seen across different populations. CPS of 1 or higher, ITT and the CPS of 10 or higher. Subgroup analysis also showed consistent results. The OS benefit was also seen across different populations, CPS of 1 or higher, ITT, and CPS of 10 or higher. Subgroup analysis also shows consistent results. Next, let's look at the final overall survival data for KEYNOTE-826. Median follow-up was 39 months. In PD-L1 positive patients, OS improved by 12 months in the all-comer population, and OS improved by 10 months in the gray population in the first-line treatment. Subgroup analysis of the trial overall survival also showed that pembrolizumab provided consistent benefit across all the predefined subgroup. Okay. Tomorrow at 2:20 p.m., I will present the 5-year follow-up data of the KEYNOTE-826 trial at the plenary cervical cancer oral abstract session. If you are interested, please join us. Not only pembrolizumab, but also the anti-PD-L1 antibody atezolizumab and the PD-1 CTLA-4 bispecific antibody cadonilimab have shown similar results. These findings provide strong evidence supporting immunotherapy as a standard first-line treatment for cervical cancer. With the introduction of the chemo plus pembrolizumab, overall survival in first-line cervical cancer has improved by more than 10 months. But does this serve everything? No. If you look at the final PFS analysis of the KEYNOTE-826 trial, even in the pembrolizumab group, more than half of the patients experienced disease progression within 12 months. This shows that managing patients after progression on first-line chemo plus immunotherapy remains a major challenge. This is still a significant unmet need in this setting. We need new mechanism of action. One promising approach is antibody-drug conjugate, ADCs. Now, Professor Serrani will talk about ADCs in more detail. Thank you for kind attention today.
That was excellent. So thank you so much, Dr. Hasegawa. Invite Dr. Solani to the podium.
Okay, so I have the privilege of talking about antibody-drug conjugates and cervical cancer. And you just saw the structure of ADC, so I won't belabor this too much. And I apologize for the size of the slide. But ADCs offer a new opportunity to deliver chemotherapy more effectively. And this is typically by targeting an antigen on the cancer cells and then delivering the chemotherapy. And I apologize, but on the very bottom right, you can see that using ADCs allows us to deliver chemotherapy with a better therapeutic window, and therefore our delivery may be more effective without increasing toxicity. And I want to focus on one of the first ADCs approved in the gynecologic oncology space. This is tisotumab vedotin, also referred to as TV. This is Huh?
The first.
The first,
Yeah,
yes, correct.
it's fun
the
to
first.
take credit for that in cervix.
Yes,
cervix
that's
never
right.
has a first. Sorry to interrupt.
And it's targeting tissue factor. And tissue factor is actually widely expressed in cervical cancer, so it's a very effective target. Tissue factor, this ADC is actually using a microtubule disrupting agent, MMAE, as its payload. So you can kind of think of it as a taxane-based payload. As I mentioned, it's highly expressed in cervical cancer, but not highly expressed in normal tissues. And tissue factor can be involved in progression and metastasis, so you see it more in advanced stages. So I'm going to start with the phase 2 data, which is Innovative 204. This is a study that was a single-arm study in second or third line cervical cancer. And I just want to show you the highlights here. Confirmed objective response rate was 24%. And you may remember from Dr. Hasegawa's slides, with topotecan, you would see like about a 10% payload, response rate. And then with the taxanes, you'll probably see in the low teens as well. So we did see complete responses in 7% of patients, partial responses in 17%, and stable disease in almost 50% of patients, really showing an impressive clinical benefit rate. Duration of response was 8.3 months, so once again, something that was meaningful and provided a benefit to our patients. Based on this data, we had accelerated approval in the United States, and this was in 2021. So this led to the confirmatory phase 3 trial, Innovative 301. And so this study also focused on recurrent and metastatic cervical cancer, and patients must have had 1 to 2 prior lines of chemotherapy. Here you can see that patients were randomized to either tisotumab vedotin or physician's choice chemotherapy with the options listed here. Just some patient characteristics to highlight. Median ages were pretty classic for cervical cancer. Most patients had received 1 prior line, and then prior bevacizumab was given in about 60% of patients. And kind of facing real-world data, we saw about a quarter of patients having prior anti-PD-L1 or PD-1 therapy. And this was very exciting to see the survival outcomes. We saw both the progression-free survival and an overall survival benefit. You can see the hazard ratios of 0.67 for PFS and a hazard ratio of 0.7 for overall survival. And if you look at 12 months, you can see 48.7% versus 35.3%, really showing the impact of tisotumab vedotin. The objective response rate here was 17.8%, so a little lower than what was reported in the phase 2 trial, but pretty consistent. And what I think is always really remarkable is our standard of care chemotherapy had a 5% response rate. So really showing how poorly we are treating our patients with cervical cancer. You can see once again that complete response, partial response, and stable disease had high rates with tisotumab vedotin, really showing good disease control rates at about 76%. I won't belabor the subgroup analysis too much, but you can really see that across subgroups, almost every subgroup benefited from tisotumab vedotin when compared to physician choice chemotherapy. And along with a new drug comes new toxicities. And so here's kind of an overview of the most common toxicities seen. You can see the darker colors representing the higher grade toxicities, and there were some of interest that I do want to point out. Tisotumab vedotin is noted in the green colors, and standard choice chemotherapy is in the brown color, and there are some that I think are important to recognize. And one of the most important ones is probably neuropathy. And although it occurs at a lower rate, my arrow up there. Okay, so here's the neuropathy, the first one at 26.8%. Smaller percentage of grade 3, but still really impactful because many of these patients have received taxane, and this can be a reason for dose reductions or dose limitations for tisotumab vedotin. Other side effects that you may see include eye toxicities, and I want to spend a little moment talking about some of the keratopathies or ocular toxicities that you may see. We know tisotumab vedotin may cause some changes in the corneal epithelium and conjunctiva, so you may actually see this with this red eye as depicted here from this picture. Patients may report keratitis, conjunctivitis, corneal ulcerations in severe cases, and vision changes or loss, although that's less common. Because of these known ocular toxicities, there are some recommendations that are mandated when a patient's receiving tisotumab vedotin. This includes an eye examination at baseline and prior to each dose, and then as clinically indicated. There is also a rigorous eye care plan that's required for patients receiving this. This includes vasoconstrictor eye drops, steroid eye drops, and lubricating eye drops, and there's a kind of a schedule that patients are given. Patients are also advised to use an ice pack over their eyes, and including their bridge of their nose, during their infusion, and then for a little bit of time, about 30 minutes afterwards. And it's important to recognize that if a patient does develop side effects, we withhold the therapy until there is improvement, and you can resume at the same or reduced dose. If it is a severe toxicity like a corneal ulceration that recurs, you may have to discontinue therapy. But I would say for those of us who have used this, it is actually very manageable. And I think that we actually talk about the eye toxicity so much more that our patients are actually very comfortable and use the preventative measures and can use this therapy very safely. The GOG is currently conducting a trial looking at the eye care plan to make sure that we're not overwhelming our patients with additional examinations or interventions. And Scott Jordan is leading this trial looking at ocular assessments with the eye care providers. What I'm really excited about is that, I mentioned that the response rate was 17%. So we know clearly this is not good enough. What else is there? So there are a couple emerging ADCs that I'd like to just highlight. The first is a HER2-targeted antibody-drug conjugate, trastuzumab deruxtecan, and many of you are probably familiar with some of the data that's come out over the last year and a half. HER2 expression in cervical cancer is not very common. As you can see, IHC3+ is about 4 to 11%, IHC2+ is about 18%. And so you don't see it often, but it can be present, and it's definitely worth checking for. So the Destiny Pan-Tumor-02 trial was an open-label phase 2 trial, single arm, giving patients trastuzumab deruxtecan if their tumors express HER2. It was tested locally, so there is some variability in the HER2 testing, and cervical cancer was one of the cohort, which evaluated up to 40 patients. You can see in the graph here that there was about 8 patients with IHC3+ on central review and about 20 patients with IHC2+. But these response rates are really impressive. 75% in the 3+ and 40% in the 2+. And this was also something that was impressive with PFS. So here you can see the HER2 status, PFS by HER2 status. The green line is kind of the all-comers in the trial. The orange line is the IHC3+. And this had not been reached at the time of presentation. The blue line is the IHC2+, and although not as impressive as the 3+, still a really impactful benefit for our patients. Once again, toxicities need to be highlighted, and we didn't really see anything that was remarkable with the exception of interstitial lung disease. We had expected neutropenias, and I should have mentioned that this is a Tecan-based payload, but we did have neutropenias. But ILD is something that that can be seen, and it's important to monitor patients for this. Because of this data, we received FDA accelerated approval for patients with HER2 3+ status across all solid tumors. And so I want to just pose to you a clinical case. So you have a 36-year-old patient from China who presents with advanced cervical cancer. She presents classically with pelvic pain and vaginal bleeding. MRI reveals a cervical mass, which looks like it's invading into the bladder, as well as lymph nodes in the pelvis. She also has a space-occupying lesion in her bladder, so consistent with a stage 4A, and biopsy confirms this. However, on PET-CT scan, she's also noted to have multiple lymph nodes in the abdomen and pelvis. She receives radiation therapy, and she also receives carboplatin and paclitaxel. Post-therapy imaging reveals that the mass has regressed significantly. However, now she has masses in the peritoneum. At this point, she receives carboplatin, paclitaxel, and pembrolizumab times 6 cycles, and after completion of therapy, a CT scan is done. She continues to have multifocal areas of FDG avid disease involving lymph nodes in the thoracic cavity, as well as soft tissue implants in the abdomen and pelvis, and now she has osseous metastasis. So outside of clinical trials, which treatment would you consider next for this patient? And I don't think we have a polling ability here, but your options would be tisotumab vedotin, cemiplimab, which is a PD-1 inhibitor, trastuzumab deruxtecan, nivolumab, which is a PD-L1 inhibitor, chemotherapy, or other. And I'll just ask for a show of hands, maybe. Anybody choose option 1? Okay, I see some hands. And I recognize that it may not be available. This has been approved in the United States since 2021, just recently getting approval in Japan, Germany, and hopefully will be available throughout the EU and other areas in the near future. In this case, I think cemiplimab and nivolumab, the patient's already progressed on pembrolizumab, so IO therapy probably isn't the most beneficial. And I hope I've convinced you that tisotumab vedotin is superior to chemotherapy. We don't know her HER2 status, so trastuzumab deruxtecan would be something to consider if she does have HER2 expression. I'm also personally really excited about the TROP2 ADC, sacituzumab tirumotecan, or sac-TMT. There was a poster presented at ESMO last year, which looked at sac-TMT with pembrolizumab, which had an objective response rate of 57.9%, and you can see a really impressive waterfall plot. This year, just at ESMO last month, we saw sac-TMT as a monotherapy agent, which had an objective response rate of 24%, duration of a disease control rate of 71%, and a duration of response of 7.5 months. And this is in the metastatic recurrent setting, so patients who are heavily pretreated. Once again, an impressive waterfall plot. And now we have a phase 3 trial, which is globally available and open, enrolling, and it's enrolling really rapidly, which once again shows the high need for better therapeutics in this area. This is looking at sac-TMT versus physician choice chemotherapy, including tisotumab vedotin, and then as other chemotherapy agents, as this may not be readily available. So we hope to have these results for you in the near future. The study is enrolling, but you are still able to enroll, so please do consider it or look for where if it's available near your area. And then lastly, there are other ADCs in development. These include different HER2 targets with an MMAE payload, and then sac-TMT, which I've mentioned, sacituzumab govitecan, which is another TROP2 target, and then a Nectin-4 ADC as well. So I think the world of cervical cancer ADC targets is still very in its infancy, but I think we have lots of good opportunities. So I think ADCs continue to be a key strategy in the management of recurrent cervical cancer. We have seen that tisotumab vedotin has shown survival advantage, and we're seeing impressive response rates in HER2, 2+ and 3+ positive cervical cancers. However, toxicity management remains a key, and it's important to know the toxicities of any therapy we're utilizing to help mitigate those toxicities. Clinical trials are ongoing. Please consider enrolling your patients, and I thank you for your time.
Thank you so much. That was excellent. You know, I really appreciate both of you, reviewing these medications, immunotherapy and ADC, specifically tisotumab vedotin, which is the only one currently available, have really been transformational in the care of these patients that really have had traditionally, severely poorly prognosis. And I know that, these medications are not available in many parts of the world. And now, at this point, after seeing so many patients do well on these medications, almost I can't even imagine not having access to these. So, I'm going to talk about global epidemiology and prevention strategies. And, we're talking and incorporating this in this talk for a couple of reasons. I mean, number one, this shouldn't be a disease that we have to treat. Like, we should be able to prevent this. But number two, if it were so easy, we would have already done that, right? So, there's so many of you in this audience that have devoted your lives and careers to trying to prevent cervical cancer. And it's just very difficult for lots of different reasons, and we'll get into those a little bit in just a second. But in the meantime, we can't just not treat our patients because we should be pursuing prevention strategies, and these patients still deserve the most effective treatments that we can offer them. So I'm just going to kind of level set with that before we hit up these details. So this is the region-specific incidence and mortality rate for cervical cancer in 2020, and it's fitting, that we finally arrived in Africa for the IGCS, and we're really privileged and happy to be here. Malawi has the highest rate of cervical cancer incidence and death in the world. It's a small country, so it's really remarkable to see these rates. In Africa really tops, these lists, but this is not just, Africa. These disparities exist globally. So these are some of the adjusted cervical cancer incidence and mortality rates across the globe. And you can see that, Africa does not stand alone in its high rates. And even in the blue United States of America, we have areas within the United States that have incidence and mortality rates that are not far off the highest rates in Africa. So we have large disparities in the United States, and these are mostly socioeconomic and political in nature. So we know that the WHO has mandated or has not, I don't know, what do we call it? They've charged us with the opportunity to eliminate cervical cancer. And while this is a possible goal, Again, if it were so easy, I think we would have already been well on our way, and I don't think we're on target, and I don't recall the year. Many of you probably know the year. Is it 2028? 30, okay, 2030. So I don't know about that date. What do you think? Yeah, I don't know. We're going to talk tonight about some ways that we are going to start to get there, but 2030 is not it's not realistically going to happen. So here's this is an example of, this is a very successful program. This says visual inspection with acetic acid, or VIA. This was a cluster randomized controlled trial. This was almost 150,000 women that participated in Mumbai, India. This is a huge clinical trial. In the U.S., we struggle to do cervical cancer clinical trials. Mumbai is not struggling. This disease is highly prevalent. Pre-invasive disease is highly prevalent. And this method was very successful in lowering the mortality rate, which is the bottom graph, with VIA. And the top graph is the incidence. So it looks kind of awkward that you would have equivalent incidence between the VIA screening and the control group, which did not have VIA screening in normal care. But it takes time for the mortality to show up. So I guess in this method of investigation that there is a lag time, and you often don't see the difference in the incidence rates. You see the difference come out in the mortality rates. So that is how this is explained. But I remember when this was presented at ASCO in the United States in 2013, there was a standing ovation. And the next presentation after that was GOG 240 with the bevacizumab added to chemotherapy for cervical cancer, which also was a great breakthrough, but it was bittersweet to see that presented after a highly likely, very effective type of less invasive cervical cancer screening. So what do you do with VIA? Many of you know Grosbeck Parham, who is here in Zambia. He has done a lot of work. One of his colleagues, Krista Fainler, is here tonight in the audience. She probably did work on this too. How do you treat it? So you find dysplasia with VIA, then what do you do about it? You need equipment, and equipment takes up space, and you don't have space. You don't have reliable electricity all the time or coolant to run a cryotherapy machine. So how do you reliably treat? And who treats the patient? So this is an example of a battery-powered portable device that takes up no space. I mean, we do this for our kitchen tools, right? We do these for things in our lives that don't matter as much as our health. And this is an example of an innovative device that can be used to treat cervical dysplasia, and when analyzed compared to cryotherapy or LEAP procedure, it was as effective at clearing dysplasia. It wasn't an endpoint in this study, but if the patient could have each procedure, which procedure was more preferable to them, that would be a really interesting question. Which procedure was more preferable to the provider? That would be an interesting question. And oh, by the way, these are operable by less skilled providers than physicians. You have folks in the community that can do these procedures that women are more comfortable with, and they'll be more compliant with the follow-up. So that's part of the beauty of Grosbeck's program that he has built in Zambia. So we learned yesterday that elimination of cervical cancer can be very geographically complex. I'm glad to see the U.S. sold out a little bit here, because complex sociocultural and geopolitical barriers are a huge problem, and it will be very difficult to eliminate cervical cancer. We have a Department of Health secretary who has said publicly that the HPV vaccine causes cervical cancer. How do you fight that? How do you fight that when there's distrust in the medical profession and distrust of physicians, and distrust in vaccines? That's very difficult to overcome. So, it depends on readiness. We used to chalk this up to GDP and how wealthy the country was, how successful they would likely be, but those probably are not the determining factors. These socio-political factors most likely are. So the IGCS is just an amazing organization when it comes to trying to put some structure, put some meat around how do we do this? Like, how do we meet the WHO goal? Where do we even start? So the IGCS is really starting to tackle this, take this on. The inaugural symposium for the Access series will be at this meeting. It will follow this meeting starting on Friday and will continue through Saturday. This is the vision and purpose statement. I'm going to have a QR code for you in a second to scan. These are the leaders of this. Mary Eichen is here. She's the CEO. This is just absolutely an amazing effort, and just proud to be part of this organization because this is how this will happen. And I'm just proud to see this taken on at an international level and us to be partnering together internationally. And to understand and care about each other's barriers and to help each other overcome them based on our own success that we've had in our own areas. This is the landscaping and analysis team, so there's really some infrastructure built under the Access program. There are phases. There's a resource and hub tool to be built, IGCS partnering responses to build these networks, and then advocacy to pull in the people who matter the most. And then this is the QR code that you can scan to get more information about the symposium. And I love how this is structured. This prioritizes everything: vaccination and public awareness, screening and treatment of pre-invasive disease, and treatment and palliative care of invasive cancer. So nothing is deprioritized for the sake of the other. This really hits all the aspects of cervical cancer care that matters. And then at the booth, you can make your commitment to this effort. And if you can join after this meeting, the reception, please do 4:30 to 6. So we're going to go into Q&A, and I thank you very much. I'm going to actually just leave this slide up. So we're going to go into Q&A, and I'm going to ask the panel a few questions about therapy, and then we're going to move into discussion. I'm going to open the floor up to the audience because I'm really glad that you guys have stayed, and I want to give you all a chance to interact with us and with each other because I know you guys have a lot of very important things to share. So let's get started. I want to just start with, the immunotherapy. We've got immunotherapy available. We've got antibody drug conjugates available. Like in some parts, hopefully we'll have them expand, as you mentioned, Dr. Solani, in availability across the globe. But in places who've access to both, like how are you positioning the immunotherapy? Like I think in cervical cancer, I hear a lot of, well, let's save it for the next line of therapy. You've got like the cemiplimab you presented in POWER. Should we just give chemo and then save IO for later? How should we position immunotherapy? Do you want to start since yeah, great.
Because if you look at the phase 3 data, we already have first-line immunotherapy. We have 3 phase 3 trials. It's very solid data, so no reason we keep these at a later point. So I think it should be one of the standard of care to use immunotherapy plus chemo in the first-line setting for advanced cervical cancer or recurrent cervical cancer. I don't think we have reason to put this to the, later time point.
How about you?
Yeah, I absolutely agree. I think the other consideration is, we're using it with locally advanced cervical cancer now with cisplatin and pembrolizumab with radiation, so maybe even earlier lines. And you showed the beautiful survival curves from Keynote 826. So what you said was, 50% recur a year. But what I think also needs to be highlighted is that curves kind of flatten out towards the end. And so we may be actually sustaining long-term survival, maybe even cures in some of these patients, which we've never really talked about before in cervical cancer. So I think reserving it for a later line is a detriment to our patients, and the earlier lines probably using it in earlier lines, whether it's with chemoradiation or with chemotherapy, probably affords the best chance of cure.
Yeah, that's my practice as well. You know, in the United States, the pembrolizumab has been restricted in the metastatic setting to the PD-L1 positive. After BCC came along without the restriction, it just wasn't measured. But now NCCN listed in the U.S., and I think this may be harder in Japan. And see, these are these global differences. Like, how are you? I think it's not pembro not restricted in Japan. Yeah, and then for you, Dr. Solani, how are you choosing IO based on PD-L1 expression?
Thank you. Oh, can I?
Yeah, go ahead.
If I may, yeah. Thank you for addressing this point, because I think Japan, approval system is very independent, basically very different from FDA approval. So Keynote 826 regimen, we are approved by ITT population. That means even the CPS lower than 1, we can use with pembrolizumab. As you can see the data, so after final analysis, how do I say? So CPS less than 1 is shifting to the, favor for pembrolizumab. And probably, how do I say? I believe still, because CPS is some kind of biopsy here and biopsy here, maybe different. So basically, I think especially for HPV-related associated cervical cancer, I think benefit for cervical cancer in first-line setting.
Yeah, I agree. It's interesting that the FDA made that decision based on a very small, number of patients, which probably wasn't statistically, meaningful. I have gotten it rejected though, and I have not yet used atezolizumab in this setting. Mm-hmm. And then, we have these challenges in the recurrent setting where pembrolizumab is for PD-L1 positive only, but cemiplimab actually shows that, when you look at the subgroups, that you have responses in both the PD-L1 negative and the PD-L1 positive. It's just not FDA approved. So my goal is always to use it as early as I can. The chemoradiation population is the place where I think we can easily get it approved because it's not specific based on CPS or PD-L1 score, but not every patient presents that way. I've tried to get it approved. I'll keep trying, but it's not always possible. So it remains a challenge.
Yeah, great. Thank you both. And Dr. Solani, you did a beautiful job presenting the data that got tisotumab to our patients. Tell me, what's your experience been like? Like, take it off the paper and describe to us, share with us, what has it been like to treat patients with this medication?
Yeah, when I first started using it, really in 2021, so it's been several years now, I was very nervous about the ocular toxicities, and so I was very, very overly cautious with patients, and I think I kind of alarmed them to the point where they thought it was not a big deal because I talked about it so much. But it does happen. I have one patient who had corneal ulcers who I had to stop on therapy, so you do still want to be vigilant. Don't let your guard down. The responses have been also, surprising in some ways. I've been really pleased. I've had a patient on cycle 13, which she's doing well and tolerating it well. She's she's in my mind because I just saw her before I came here. But there are, you have to be careful because not every patient's going to respond. And so, we typically do scans after every 3 cycles. That may be a, time to evaluate the patients, and then they may come off. It's just hard because there's not other good options at this time.
Yeah. Couldn't agree more. How about you, Professor?
I think we just started to use sotumabetotin in Japan. I think started from May, so we just started it. But we joined phase 2 trial and phase 3 trial. We already have some experience. So honestly, when we do the trial, I don't have a good feeling about some better thing. But now in the real world setting, we start to use from May, and some response very well. And this response is kind of not just like the how do I say survival. It's kind of some duration to me. So maybe I think tisotumab is a great option after immunotherapy failure. So far, I'm not sure maybe this also moving from line setting, but so far I think it's a good option for the second-line setting. And in terms of ocular toxicity, because we don't have, MIRV is not available in Japan. So ovarian cancer, metastatic tropotas, this is first drug to us to manage the ocular toxicity. Now we feel very scared for first time.
Yeah.
But again, actually, most of them is very mild. And we discuss with ophthalmologist and try to sometimes reduce the dose, also try to manage that. And usually, I think the eye symptoms recover quickly to my impression. So probably I think that is not very difficult reason to not use the tisofovir.
May I make a comment?
Yeah.
So you're exactly right. The ocular toxicity data from the trial showed that it recovered usually within a month. So, there is a quick recovery with appropriate management. And I just also want to highlight that, I mentioned that response, but I also think stable disease is a victory for us in this setting. And a lot of patients will have stable disease. So keeping patients on therapy, minimizing toxicity can really provide some long responses or duration of treatment because of stable disease.
I love that you both feared the ocular toxicity. It just means that you're good doctors and you care about your patients. So I have a lot of respect for both of you for that. I think we all did. For me, I've had more, the neuropathy has been a little bit more challenging. The ocular toxicity has not been. It's been mild. It's been surface toxicity. It's been fairly easy to treat with dose holds and reductions. And the neuropathy's been manageable, but a little bit more. It has a motor component. It's a little bit more difficult, different than Taxol. So there's a learning curve with that. But I think the responders to this you really remember. So I had a patient with a malignant bowel obstruction who was on her way to hospice, and her daughter was getting ready to graduate college, and she just she wasn't ready. She wanted to make it to the graduation. We had a counter, and she had on her phone like the countdown of the days. And so this had just become available. Like this was literally 2021 when we had just gotten it. So we started her, and by the third cycle, she was in London with her husband having dinner and, sent me a picture and looked like a completely different person. Like it was one of those sentinel events. It was like your first Len-Pem patient that did well, and you're like, oh no, I gotta learn how to do this. But it was pretty remarkable response, and that lasted for almost 2 years. So not everyone's going to respond that way. That's an exceptional responder, but it gives you an idea of what's possible with that. So just a few more minutes. Just want to open it up to the floor for questions, comments. Thank you all for staying. We've got warriors in this room. Thank you so much. Yeah.
Hi, thank you very much for great presentations. Gabriel Levin from Montreal. A simple clinical situation. You have a patient, locally advanced. You give her A18. What would you do if she progresses during maintenance treatment or she progresses later when she's off treatment? How do you sequence the treatment?
That's a great question. I think we're debating a lot of like, at what point does she progress on the IO? I personally believe that if you retreat with an immunotherapy, you need some sort of combination therapy, and those are currently available more in a trial setting. So technically, you would give a GOG 240 regimen at this time for that first line treatment, and then your second line treatment, you're moving over more towards like a tisotumab vedotin. We see patients from Canada who want tisotumab. They come to America and they're begging to see if there's some way that they can get. And we see them in the chat rooms on the message boards. And so hopefully that will become available soon for you all as well. Do you all do anything different?
No, I totally agree, and I'm not quite sure what the role of IO re-challenge is in patients. I mean, clearly 240 or chemotherapy with bevacizumab would be appropriate, but I think it's a provocative comment because I do think IO combinations, whether it's tisotumab vedotin and pembrolizumab, which there's data for in a phase 2 trial, or whether it's a CTLA-4 target, I think there's opportunities. I don't think we're there yet, but it's always a frustrating situation when you see that.
Thank you. Yeah. Any other questions, comments? Any comments on the global uptake or, this is I think our biggest barrier, the thing that it bothers me that, I'm glad my patients have access to these medications, but it bothers me that so many patients don't. Bothers me that these medications are approved in areas where these patients are not located. So I don't know if anyone has thoughts about that or anyone doing any work on creating access for novel therapies globally.
And I will just add that, I think we all recognize the importance of screening and vaccinations. We don't mean to, obviously that's really the key to prevention, but we all know that those still don't capture 100% of patients. And you heard about the mortality and incidence rising in Japan. There are definitely areas in the United States where this continues to be an issue. So I think we need just like the IGCS access program is targeting kind of all aspects of cervical cancer, just want to be mindful. But I would say that, the key is really prevention. But I do think access to these therapies is a huge issue because we have probably worsening of disparities now that we have different therapies across global regions.
See, that's a hard topic. It's like, who's the answer? I don't know. Just keep thinking about it, keep working on it. The access program. Great. All right, well, we're going to let you guys go early. So thank you so much, everyone. Great program.